Hello and welcome back. For those who got to watch some of the poster presentations, thank you. You've seen maybe about half of them. Um, Please go to our YouTube channel and catch all the poster presentations and the lectures that we have put up there. I'd like to welcome you to our panel looking at just societies. We're going to be looking at Canada's drug laws, medical aid in dying, and experiences of homelessness. We are pleased with the return of our moderator for this session, DWP Board Chair, Dr. Michelle Hewitt. She's in conversation with Nicole Luongo of the Canadian Drug Policy Coalition, researcher Dr. Ragan, and Emilio Toala, whose research intersects with lived experience of homelessness. Michelle, over to you.
Hi there, and I would just like to take my moment here as chair of the board of DWP to do a few shout outs or thank yous before we move on to our panel. So, in the background, there's an amazing team making all of this happen and have been making it happen for quite a few months. So, I'd like to give a shout out to Liz at Plan Institute. They have our back so many times. They run our webinars and all kinds of things. It makes it look effortless, and I know that they work very hard. So thank you. Today, behind the scenes, Amanda, Sabrina, Amy, and Omar. Oh my life, people! You are doing such an amazing job. As Amanda reminded me a little while ago, I just said, how about we put this little symposium on? And they've made it into this incredible event. Amanda has been she's had my back through the start of this and come up with help to make ideas that I put into place. Like, we had so many people get in touch to say that with amazing ideas, and rather than say no, we decided to do things like this: bring together three amazing presentations under one umbrella. If you have not had the opportunity, please do take the time to go and watch the videos that each of Ty, Nicole, Emilio have put together. And Emilio, I have to give a shout out to Grace. The graphics, oh my life, she's amazing.
Yes,
So
absolutely. I'm so
yeah,
proud I was able to
well,
bring
you,
her.
you should be. You should be.
Yeah,
I think
I'm so happy with how it came out. I believe she's in the audience right now. I hope everyone gets the chance to take a look and see the amazing graphics she made for me. It's beautiful, and I'm so appreciative of it.
the one at the end, looking down at the feet with the shadow. Oh my goodness. I think it's just absolutely. So I'm just going to give a very brief introduction to me, other than being chair of the board, because it may well come into our discussion. So I'm a disabled woman, full-time power wheelchair, limited spoons, you name it. My own research is dis, younger disabled adults who have no other option than to live in long-term care facilities. So are often in places where everybody else is like 40 years older than them, and the systems were built for people of that age and not for them. And I see intersections with all three topics here. And so I just wanted to put that out front. I think this is so amazing to be here for disabled academics having a great conversation together. So I'm going to ask you each to give a brief introduction, so that everybody else, if they haven't had a chance to have a video, knows who each of you are. So Emilio, as we have already heard your voice, would you like to just give us a brief intro?
Yes, absolutely. Thank you so much for having me here. My name is Emilio. I use he, him pronouns. I'm currently wearing a white and black checkered patterned sweater. I have a gold chain. I'm fair mid skin complexion, and typically I'd be wearing a mask, but I'm doing this presentation from the comfort of my own home. I'm a person with lived experience of homelessness and living with multiple invisible disabilities. I am also an academic. I work in places like Unity Health Toronto and the Center for Addiction and Mental Health. And I do research on multiple different things, including crisis line services and homelessness, housing, and health. So a lot of these things really do intersect with many aspects of my life that I personally deal with, and they intersect with things that people in my life also deal with. So it's something that's very near and dear to me. The lecture that I presented for this panel was on the intersection between disability and experiences of homelessness, and it really looks a lot at disability as a very broad and all-encompassing experience across Canada. So that includes mental health and physical health, and looking at how that relates to experiences of homelessness. So I really thought of it as kind of this pathway. So you could think about all the branching paths that people might take that might lead from being a person living with disabilities to experiencing homelessness and then navigating through the system and making your way back out. And I think the big takeaway for me on this initial journey, because it's really just something that I'm starting in for the first time and I'm looking forward to continuing in this space for a long time to come, is that homelessness really is a disabling experience. So when we're really thinking about that social model of disability, the world around us and the way that our system is set up is really what leads to homelessness for one. Two, it leads to homelessness for certain people, for example, people with disabilities, much more disproportionately compared to others. And then while you're experiencing homelessness, that's also a disabling experience because of all the circumstances that you are facing. They really do lead to either an exacerbation of what you're already experiencing, or they lead to newfound disabilities that happen while you're experiencing homelessness. So I really am honored to be here, and thank you so much for having me.
Thank you. Nicole, I kind of think that disabling experiences, as soon as Emilio said that, I thought I could see you kind of nod and that would be something that would resonate with you. Would you like to introduce yourself and give a Cole's notes to your topic as well, please?
Absolutely. Thank you so much. Hi, everyone. My name is Nicole Luongo. I use she, her pronouns. I'm here today on behalf of the Canadian Drug Policy Coalition, or CDPC, where my official title is Systems Change Analyst. What that means depends on the day. But a little bit about me. I'll also just say I'm speaking from a room that is not the, I just moved. It's a little dimly lit. Apologies. Still figuring
It's
out the
all
lighting
good. It's all good.
situation. But wearing a blue and silver and black sweater. I'm white and have kind of shoulder length brown hair. And so, yeah, I work for the Canadian Drug Policy Coalition. I'm in my fifth year now with CDPC. I too spent many years homeless as a young person on Vancouver's downtown east side, where I was engaged in criminalized drug use, and kind of all that comes with it. So for me, that looked like a cumulative total of many years of involuntary institutionalization, um, probably apt to refer to it as incarceration. I'm also mad and disabled in myriad ways. And yeah, these days I live in Toronto. In terms of my presentation, I was nodding along to the word disabling because I use that term myself specifically in the abstract. So I really covered how Canada's drug laws and policies, which criminalize some drug possession and many activities related to it, uh, do function to disable individuals and communities. And I'll just say at the outset a bit of a note on terminology. When I use the term drug prohibition, I'm referring to the legal architecture that does criminalize certain drug-related activities. And you'll hear me use the term drug user. I know kind of the, I guess, more sanitized or PC term now is person or people who use drugs. As a drug user or former drug user, I'm not too caught up on it. And I do want to like kind of emphasize at the outset that many people who use criminalized drugs are not experiencing what we refer to or what gets diagnosed as substance use disorder. And that is actually quite important when we talk about policy objectives. And then you'll also hear me use the term unregulated drug crisis. So we often hear the term still opioid crisis or addiction crisis, and that's actually a bit of a misnomer. Rates of substance use disorder diagnosis, rates of drug use have not really increased in the last decade, but rates of overdose fatalities have skyrocketed. And that is because the composition of the unregulated drug supply has changed. And so I just want to kind of emphasize that at the outset. And so the bulk of my presentation really is oriented around kind of walking through how prohibition is disabling, how it causes first physical disabilities such as through hypoxic brain injuries, but really I elaborate on how the institutional trajectories that people are subjected to vis-a-vis prohibition kind of disable them and us socially, economically, things like that. And then I spend a bit of time on solutions and policy solutions to the unregulated drug crisis, the kind of first and foremost of which is actually legalizing and regulating the illegal drug supply. And I'm very happy to elaborate on that because it often elicits a very strong response in people. And I hope to kind of prompt all of us to think and talk about how disability justice spaces could be more accommodating to people who use criminalized drugs. So I will just leave it at that for now. Thank you.
Thank you, Nicole. And Ty, again, I could see you nodding along because, I think having watched obviously your presentation and having spent a fair amount of time in the MAiD space in some research myself, that when we talk about policies and disabling policies and how things, I imagine that that's something that you're going to want to talk about, but I don't want to preempt your own speech. So Ty, please introduce yourself and the area that you've covered for us so far.
Sure. As was announced, I'm Dr. Ty Ragan. I don't use the doctor as being pretentious. I actually got my doctorate because I was running affordable housing for those exiting homelessness and substance abuse, veterans, and those with disabilities. And I was frustrated because of the lack of supports from my team as well as our residents. So it was actually a practical outcome because I looked into all those what we call micro credentials now, and the cost was equitable to get what my team needed and my residents needed. And as I've functioned through systems over 15 years using it, it opens doors a lot quicker than phoning and saying, "Hey, this is this guy. Can you help?" You leave a phone message,
I
unfortunately.
don't want to interrupt, having just given the floor, but I want to say I got my doctorate for exactly the same reasons because
Hmm.
people were not listening. So it's okay. Let's get those. So my team know that I'm very. I try to be very light with my use of it, so
Hmm.
that when I do use the term, it's like dropping the hammer blow. So sorry. Over
No,
to you.
that's what the systems that support my medically complex could have found out. If I introduce myself as Dr. Reagan, we already have a problem. I'm a dad of two amazing kids. One is they're both adults now. So we're navigating that space here in Alberta on Treaty 7 lands with a government that doesn't always live into the social contract of thrive. They rather have you in survival mode. And so, yeah, as you said, I've come into the space of MAiD work and research through a variety of different areas. Um, I remember being engaged with those conversations in the early days with Sue Rodriguez when I was in school around the dinner table, and then Robert Latimer's murder of his daughter, and also different advocacy work, walking with staff as they've discovered what their value set is around it when clients want to engage with it, but also with residents and clients themselves and their families, and asking, what does this mean? And as we explore the disability landscape, knowing it is one of the broadest demographics we have with multiple intersections. We have folks like ourselves here on this panel across the entire spectrum, down to like my son and his buddies and peers. And it can create a very hard way to create a unified voice for advocacy and needs to thrive because it is that sliding model and the responsitory need that our 14 different health jurisdictions and disability jurisdictions like to play hot potato with in Canada, if you will. Same reason we have so many cracks people fall through with MAiD. Um, and it doesn't help that we have a eugenics underlying theme in Canada since colonization. The first time my province attempted, sadly, we were successful 4 times this past month, but the first time they attempted to use the notwithstanding clause was to silence those forcefully sterilized in the disability community. And our cabinet at that time got a backbone and said no. So we have this under there. We also have this long script that I encountered working when I used to be in the field in the houseless sector of everybody who gets an entitlement or everybody gets supports as a debit because we create this fallacy that government budgets function as a bank statement in our own personal bank statements. So this is just a fallacy, but they say this is all a debit on our columns and no credits. Now, as we've heard from other speakers this morning in different panels, no, there is a follow through that provides and actually creates a better fiscally responsible framework when we give the proper supports for thriving. That's one of the other things we have to come through. And then this challenge of coercion. When we dive into the stats, a lot of it deals with poverty, lack of dignity. We have, as you hear dive into the statistics, close to 40% of professional caregivers saying they're not trained properly to provide care for persons with disabilities or chronic conditions. Then you exacerbate that with houselessness and trying to provide those. We did a lot of attempts to make shift works in shelter systems for persons with disabilities because there was a lack of affordable and accessible housing for them. So those compounds, substance use, a theme throughout. A chicken and the egg scenario in some cases when it comes to the trauma of houselessness, but also how many times are folks on prescribed medications, but others in their lives will coerce them to try something else that works better or overuse something. And then the past month here, November 2nd, the Canadian Affairs explored advanced directives they made. I just want to share this, but 40% of physicians saying they don't know when to bring this up in conversation. That's the other coercive piece. The legislation says the physician, clinician, nurse practitioner can't. It has to be patient initiated. And we already know that 1 in 3, when the clinician initiates it, will say yes right away. And 2/3 will be there mulling. So we have those pieces that fall into play. And so these intersections, the same intersections we see in the coping mechanisms that people use substances for, or what we call process addictions or behavior addictions, and with the trauma of houselessness. Those intersect. I use the term houselessness here to talk about the affordable and accessible and appropriate housing models for everybody. Homelessness for me comes into my area of actual research, which is around belonging. And belonging is that ability to have that space that is yours. And just think of when you hear the word home, a healthy home, what does that mean to you? And you have connections. You have people that care about you. You have people that you care about. Maybe you have a pet. But it's yours. And you're known in your community. And if you disappear for a bit, people worry. Those are the key things that are also missing when it comes to people accessing MAiD. It's not just about the imminent end of life or the chronic condition or disability like with track 2. These are the things that are missing. Same things we hear about in those other intersections of the Justice Society. Things that the government can respond to, communities can respond to, but we've changed the vernacular. We don't talk about residents. We don't talk about citizens. We talk about taxpayers. We've set a threshold that says you must be above the poverty line giving us money before your voice matters.
So let's pick up on that. Let's pick up like this panel. Amanda came up with this wonderful title about us a just society, and I'd really like us to explore what for each of us, as you've just talked about, the terminology that's used has switched, and we have this sort of the predominant neoliberalism that says that people are only measured by their value to society, by the worth if they're able to work and earn money. So, Nicole, if we were to shift into a more just society, what would that look like for the people that you work with and in your areas? What would that be in terms of, um, given how Thai set us up so beautifully?
Yeah, I mean, from my particular vantage point, there are, of course, many responses to that question.
Of
But the
course.
one, the one I'll focus on for the purposes of today is emphasizing the need for the end of drug prohibition. And in terms of what that means practically, that would look first and foremost like eliminating sections of Canada's Controlled Drugs and Substances Act, which is kind of our federal regime of prohibition that criminalize drug possession for personal use, as well as all of the activities related to it. And in place of that, there is such a vast array of possibilities of how we could do things differently. Our organization discusses the need to implement models of drug legalization and regulation that are grounded in the principles of public health, but even more importantly, I think human rights. And I
Right.
emphasize regulation along with legalization because I'm not advocating for a for-profit or market model of drug legalization, which we, of course, see with alcohol and now cannabis. So a truly just model would be not for profit and exclude corporate interests and also account for the disproportionate harms of prohibition, not just for Indigenous, racialized, poor, disabled, etc., communities domestically, but also the harms of prohibition for nations in the developing world who are being immiserated under the guise of the war on drugs.
Well,
Um,
we don't have to
yeah.
go too far into it, but look at everything that's happening off the coast of Venezuela at the moment, right? That we have basically war crimes being committed at the same time as the president of Honduras has been set free, having been convicted of massive drug um, laws. I'm sorry. As the day goes on, I get tireder and I lose my sweet speech a little bit. I didn't want to interrupt you. I was I you really made me think in your presentation when you talked about prohibition brings with it a drug supply that I think most of us know. We hear, or we see even on TV dramas that drugs have been cut with other things. But that in itself is disabling, right? And I'd not really put those two things together. Can you just elaborate on that a little bit? How the actual, by prohibiting drugs, the illegal supply in itself becomes disabling.
Absolutely, yeah. We refer to something called the iron law of prohibition, which the most succinct way to describe it is the harder the enforcement, the harder the drugs. So, 100 years ago, we experimented with alcohol prohibition, and the results were very comparable to what we see today with other substances. There was still a market demand for alcohol. People continued to drink it. They just couldn't procure it legally. So what that did was kind of incentivize this vast, organized criminal network to proliferate. And there are no regulations when you produce a substance illegally. And so what we saw then and what we see today is drug manufacturers kind of at the highest end of the supply chain, I'll refer to it as, adding these adulterants to the drug supply uh, to kind of make it as cheap and efficient as possible to garner the same effect. So we're doing nothing to address demand for drugs. In fact, demand for drugs is also being incentivized because of increasing rates of poverty and homelessness and inaccessible health care. But from the supply side, things are just getting kind of more potent, more contaminated, less predictable. And then that leads to a host of disabling experiences. Foremost among them, of course, there are physical disabilities that result from things like repeated overdoses. But more than that, because the drug supply continues to be illegal and access to it is criminalized, anyone who wants to seek support is really risking everything by reaching out. They don't know how folks are going to respond. And so we see this cumulative toll being taken. And it is, of course, a global system. And I really also want to avoid kind of erecting an artificial binary between, nefarious, sinister drug dealers and vulnerable victims who use drugs, because often people who use drugs and who sell drugs are the same people. And again, it is largely Western interventionism throughout Latin America and the rest of the developing world that creates organized criminal activity. And so, again, returning to this idea of a just society, our utopian vision would be to eradicate prohibition globally and actually import kind of the key ingredients in drugs, the opium poppy, things like that, from those same small scale producers,
Yeah.
and ensure that kind of there's a reparative element of that as well.
Thank you. So, Emilio, this morning I was in a presentation with Latonya. Sorry, Latonya. Again, as I say, later in the day, my speech becomes a little shaky, and she does a whole load of research into housing and homelessness, and she gave this startling example of somebody who had been assessed that lived in, as the terminology, an encampment, that was assessed to move into housing, but because of their disability needs, diabetes and some other needs, there wasn't housing that they could move into. So ultimately, the team assessing them decided it was safer for them to stay homelessness or houseless, as Ty would also say, and live in the encampments. I just, that does not seem like a just society at all, right? And obviously there are so many aspects of homelessness that are not at all just. I just wanted you to reflect on, a just society and homelessness for us.
Yeah, I think there was a panel earlier discussing housing first, and I think
Mm.
housing first is kind of one of those solutions. But the challenge with housing first is that we have what they like to call a very limited housing supply. So they like to tell us that, the market's very tight. There's not really much going on there. You kind of have to take what you're given. And when you take a look at what you're given, for example, I think of Toronto community housing as one place that people have to take what they're given. And when you go into these units, they're very much in disrepair. They're very inaccessible. There's no physical space for people to be able to navigate if they have accessibility needs. The mental health needs are most certainly not there. You have pests, you have poor maintenance, and there's just so many different factors that are going into somebody's housing experience, even as they're transitioning out of homelessness, that um, it results in either somebody not choosing to take a house, and so they continue to be houseless, or they end up in a situation where they end up back into houselessness because the unit that they've inherited just isn't working for them for multiple different reasons. But I think one of our more recent estimates on vacant housing in Canada showed that we have as many as 1.3 million vacant homes. So I think part of what a just when I say part of this, like I really do mean like one part of a just society is allowing everyone to have housing. I think it's very much as simple as that, but it doesn't stop there though, because as we mentioned, the services and supports that are necessary, especially for people with disabilities, are quite pertinent for somebody being able to maintain stable housing. So as Ty mentioned a little bit earlier, a lot of people, they aren't prepared and ready to serve the population of people with disabilities, and this is also true for people with disabilities who are experiencing houselessness. So a lot of the services and supports are built with able-bodied people in mind. So a lot of policies, procedures, standard operations, even at the academic and institutional level, the training that people like social workers and substance use counselors, the things that they're receiving are very much with able-bodied perspectives in mind. So even when those services and supports are being rendered for people like myself, very much like myself, I want to remind the audience of that I'm a person with disabilities who also experienced homelessness. The services that people like me are receiving are very much not prepared to meet the needs that we have. And like that can very much look like, it looks like people are giving up on us because they call us very complex. They call us, we're hard to engage, we're hard to reach, it might look like we're giving up because the services that we're receiving, they're not meeting our own needs. So I'm like, well, why would I care about the services that I'm getting when you're only meeting maybe one very basic need, but you're not meeting all these other needs that I'm having, like my mental health considerations, my physical health. Like I do have physical health concerns as well that I don't often mention because it's just something I like to bottle up within myself as well. That they're often not addressed as well, and when there's those services and supports are not there, then they can relate to people experiencing transient housing, going back into homelessness. And so those services and supports also have to be in place. But then there's this third part about affordability and stability that has to be addressed as well. So, we there was conversation about ODSP. So I live in Toronto, Ontario as well. And ODSP most certainly does not cover all of the living expenses that somebody might have in the city of Toronto when the average price of a one bedroom apartment here is around $2,100. So when you're only getting $1,100 and maybe you're trying to make something on the side, either through paid work or other means of finding employment that could either be legal or illegal, if you will, those revenue streams are not enough to cover everything that you need in order to support yourself. So I
Right.
think that the other part has to be having the support that's necessary to not just live an affordable life, but also a dignified life. So being able to have
Absolutely.
like recreate,
Absolutely.
like family, like even just those little things that really do make a big difference.
I just want to give a shout out that I gave into my previous panel as well to an amazing program in Vancouver called The Right Fit that took accessible housing out of the general supply and made it fit to disabled people's needs. And it was put together with Jane Dyson and Christine Gordon at DABC a few years ago, and Paul Gauthier from and the team currently at DABC continues to work with it, and Paul Gauthier and his team at IFRC. If you heard Stephen talk earlier, he was being released from hospital to the streets. For if it hadn't been for the right fit plus direct funded care, those wraparound supports. And I think, Ty, as we lead on to you, I think, when we talk about MAiD and we talk about policy choices, I have to say a lot of what you said about, it's not that MAiD exists in this place where other systems have eroded. And so would MAiD still exist in a just society in Canada?
I think it would because it is about life autonomy. But what we would see is less usage because of the ancillary reasons. And they try to create some smoke and mirrors saying, well, only 25% of people access MAiD live in poverty. Okay, but what if that 25% wasn't in poverty? What would their decision have been? What if that 25% didn't have to navigate a system where if you have to go through three different governmental agencies to get a shower chair, where you are on a wait list to access a grant to see if you can put a lift in your house, you don't have to move out of your housing, where you're able to have a spouse and not have your entitlement judged on this spouse's income and assets. And so for a just society, for me, I'm going to try not to use colorful metaphors as Mr. Spock would say, but it really is removing the idea of survival to thriving. We, as I heard in another panel, and I'm sure I've read some results before, all our disability supports are designed around this fact you can still work. Everything we know about disability research, including myself with my disabilities and neurologies, there's great seasons and not so great seasons. Decoupling them is a brilliant thing. An even better thing, because we tend to lock into this ableist work manifesto, so things are designed from 18 to 64, because before 18, who cares? And after 64, well, according to my previous premier, you're past your best before date, so during the pandemic, it's okay if you expired. We forget what a just society would be looking at what needs to be built in place from birth to grave to allow for thriving. We wouldn't see wait lists for early interventions. We wouldn't see wait lists for childhood supports. Childhood supports for those families would not be reimbursement models. They'd be covered models, so every family would be on equitable footing regardless of economics. Adulthood would be a seamless transition, not incurring other costs. We wouldn't be looking at things like Bill 12 in Alberta, where we're going to be moving people off AISH to a work program and then having reapplications or debate whether or not they're palliative and shrink the amount you can make without dollar for dollar clawbacks. The CDB would not be this ambiguous red tape thing that creates confusion and doesn't really help if you live in a province the size of clawback. Adulthood would be a universal basic income. You make more than that, the CRA knows what we're making, people. Let's be real. They can do the slide backs. We wind up unemployed, they can bump it back up for us. We retire, it can still be there. Why do our seniors, if you're on a disability entitlement, and then you retire, you wind up making less? So now we've confounded an issue with MAiD where you retire and you're disabled, and now you're making less than you were making in poverty when you were in poverty on the disability entitlement. Now you're making less. And in Alberta, you have a cost share now for your drugs, your pharmaceuticals. So now what? When we talk about poverty, we talk about dignity. It's a lifespan issue, and a just society says everyone needs to have that equitable playing field to thrive. And whatever challenges we experience have ripple effects in our communities. Whether that's what social disorder is, that's those ripple effects. And how do we help as a community navigate through those? Sorry, Michelle.
So you really speak our language at DWP. And I just want to remind everybody that today, one of the things that we've done in conjunction with this, like we must have, I don't know what we thought about doing this at the same time, but we decided to, we released our third annual report card. Mm-hmm. And all of the statistics, all of the situations that you're talking to, rather, are backed up by statistics in that report card. So any of you in your research, if you're looking for a great place to get that one-stop shop, to find all of the statistics to bear it up. Now, we have a hard stop at, 12:20 my time, so 20 past the hour, wherever we are. And so we've got 14 minutes left. I'd really like to just open it up and tell, we've all had a bit of an introduction and we've talked a bit. Tell me what you're thinking, any of you, on what we've heard today about the intersections of each of these three areas. I mean, for me, I see the barrier in everything that we're talking about here as attitudinal. The attitudes to disabled people, whether they be, I smile when, Nicole, when you were like, is it drug users or people that use drugs? Well, I'm a very much, disability first person. I talk about disabled people, not persons with disabilities. And as you said, drug users are going to describe themselves as drug users because that's what we all tend to do. So, but that attitudinal place of who we are and what we are. I told this story in the earlier panel. I went to my local Dollarama on Saturday evening. It was dark and miserable, and the push button didn't work. I'm in a power wheelchair. I have a service dog, and a young man, 20s, 30s, came steaming up on his bike. He could be a young man that had homelessness. It was somebody that's life, I would say, was complex for. Immediately, let me get the door for you, let me help you. I said, do you not need to lock your bike up? No, everybody in this community knows me. It wasn't they know me. It was, everybody knows me. Nobody's going to touch my bike. I got inside. A local group home was there, one-to-one people with their carers doing their kind of weekly shop. And aisles in Dollarama aren't built for a power wheelchair and a dog. Every aisle, one of the disabled people said, how can I help you? I went to leave the place. Again, somebody else, because the door still wasn't working, obviously. I left that place on a Saturday night thinking, this is what everybody needs to see. I went through this shop and came out feeling valued, assisted, and part of a community. And to me, that's what my society, that's who I live, that's where I live, that's the people I see, every day as I walk Leo. And so, I just want to talk about the intersections of this, the sort of the communities you represent today. I know we're not, we're more complex than that. And I've taken some of the time. We now have 11 minutes left. I open the floor to you.
Yeah, I guess maybe I can go first. I think one thing that I'm really thinking a lot about that keeps popping into my head is Doug Ford. So I live in Toronto, Ontario, and very recently Bill 60 passed, and that's something that's very much on my mind as somebody from multiple intersections that we've talked about today. And I really think a lot about like that rhetoric that comes through of he likes to say a lot like get a job, you know. People he thinks of us as lazy, and like if and I see it among people all the time too. I'm on TikTok because like that's where I get a lot of the news about these things as well. And people will say, "Oh, if you're a good tenant, it should be okay. If you're a tenant who decides not to pay your rent, then this is your fault." I think I think a lot of it really is attitudinal first and foremost. It's a lot of that NIMBYism that like as long as I don't have to see it and as long as I don't have to deal with it and it's over there, then it doesn't really matter. But I think a lot of people don't seem to realize that disability is right around the corner, right? Like you have no idea when something can happen to you either mentally or physically that can put you in the exact same position, and you'll have wished that people would be advocating for you in the same way that you would hope to advocate for that another person. And I think that's really on my mind today is just like as these things continue to kind of escalate and cascade as we for whatever reason follow our neighbors down south, we really need to kind of focus on kind of changing that rhetoric and getting the word out there that there's a different reality than what you think it is just because you see that online.
Hey, so Nicole, I see a question for you in the chat that says, with the legalization of marijuana, putting aside court decisions, do you feel that medical marijuana would or could receive a DIN, like a drug identification number, I guess? Is that something that you feel you can answer?
I'm looking in the chat and for some reason don't
It's
see that.
it's Kim. Her little thing is a cat's face. If you can see that, I'll read it out again a little more slowly.
Sure, sorry, I could be having a tech issue on my end.
No, with the legalization of marijuana, putting aside court decisions, do you feel that medical marijuana would or could receive a DIN, a drug identification number?
It's tough to say. I'll be frank and say we've made a lot of errors on the way to cannabis legalization, predominantly because we didn't prioritize equity and we legalized through a for-profit or market model. And so to retroactively, I'm assuming the question is kind of alluding to is it going to be possible for folks to be prescribed medical cannabis or,
I don't know. I mean, I guess, you can be prescribed in the sense that, that before it was legalized, we could have said that
yeah.
you got a medical marijuana. But I wonder if that's a supply chain position or even just prescription, get it through the pharmacy. Kim's got her
Yeah.
hand up. Kim,
Yeah.
would you like to give us a little more? Go off mute if that's possible. I don't know if it is. I'm not sure how our system is working today. Okay, so Trevor's saying he's a medical cannabis patient, and I have been as well. I used to take something called Sativex, but it was no longer covered by my drug plan, so I stopped. And that's one of the things that happens. Hey, Kajida, I'm sorry, I've probably absolutely butchered your name. If you'd like to put your question in the chat, I'd probably be able to get to it. And yeah, Kim, no, it's not possible to come off mute. So Nicole, is there anything you'd like to add to that? I mean, attitudes, right? When it comes to drug users, I'm looking. We have 7 minutes, and so I want to give Ty another ability to come back as well. So, attitudes and drug users. Where do we begin, right?
Where do we begin? Yeah, I mean, and it's, debatable whether attitudes shape policy and law or law and policy shape attitudes, probably a bit of both. What I have been thinking about, what I'm always thinking about a lot, and kind of what prompted me to even apply for this conference is just the extent to which we have more in common than we do different. I'm technically here representing the drug policy perspective, but ultimately, all of us who are disabled, whether innately or by political economic forces, I think our adversaries are kind of those same systems, right? And so, although that is challenging insofar as it can be hard to even define disability when, as we've covered, our environments are disabling, I think that also offers a lot of opportunity to engage in solidaristic struggle. So my hope longer term and what a lot of my role is oriented around is kind of looking at those intersections and building those bridges among different social movements because
And
yep, sorry,
yeah,
go ahead.
yeah, no, I have to say at DWP, that's something we really tried to do with our Shape the CDB report because um, our friends at Inclusion Canada did a report for the government for their disability inclusion action plan, and it literally lists on page 32. I talk about it a lot. All of the people that they couldn't reach, and so we
Mhm.
set out to do a report that reached those people, which leads on to Khadija. I'm going to pronounce it differently again. I'm so sorry. She says, can we address domestic violence against people with disabilities, therefore leading to houselessness? What protections can they have in place? And are people with cancer considered people with disability? So, you've just given us a whole new panel for the next time that we do this. And Nicole, I think that you're absolutely right. I think that by putting ourselves in silos, because I think sometimes as different equity seeking groups, we think we have to really just champion our corner because we're all desperate to get something, and we've got to let go of those silos, right? We've got to work across the silos, across the intersectionalities, and through that put together a bigger position. So, Ty, I'm just going to move on to you because you have this unique perspective of living out in Alberta. You know, the
I
only
wish one day we would be
province,
unique.
yeah, yeah, the only province that decided to claw back the CDB, the
Yes.
only province that then came up with another version that then is $200, magic $200 lower in the ADAP, right?
Yeah.
Um, and
And
here we
reduces
are
the
to
ability to earn by $800. So it locks in at
and put
$350 a month.
and put up the price of social housing at the same time.
Yep.
Yeah.
Yep.
All at once. Because clearly, disabled folks in Alberta are doing so well that their government needs to come down on them so
Mm-hmm.
hard to stop this embarrassment of riches that they clearly, I'm being sarcastic, people. Ty, talk a little bit then we have 3 minutes. Talk about attitudinal, because I mean, the Albertan stuff has those attitudinal barriers written all over it.
We are the heartland of misinformation in Canada. It's been proven evidentiary, and I live it. Touching on the question about domestic violence, part of this is the fact that we have this misinformation. People move to Alberta with disabilities because we give so much money. I don't know if anyone's ever explored actually validity moving a province when you have all those intersections. I made it through the paperwork once to transition my child to adulthood. I don't know if I want to do it again. There's a lot of legal stuff. There's a lot of reconnections, a lot of, and so yeah, the attitudinal piece. It's rooted in a very moralistic lens. Same thing the Ladane Commission talked about drug policy back in 1970 about when they traveled Canada, and we're still haven't got there. Same thing around housing and around people who are houseless. This idea of, well, you've done it to yourself. Well, you could just work yourself out. You could just pull yourself up from your bootstraps. All those metaphors to make you feel bad. So we ignore the system, a capitalistic system that says we shall have less thans in a system like this. The question that nobody wants to ask moralistically is, what level are we comfortable with as society? And currently in Alberta, societally, we're okay with kids living in cars under bridges and disabled people not being able to get the supports they need, and it's okay if they access MAiD instead. And we even have clinicians advocating for that, regardless of where you fall on the spectrum. We have the Vibrant Communities Calgary Report 2025 had 92% of disabled Calgarians saying they live in fear of domestic violence. And to touch on what could solve that, well, why can't your partner qualify for all these supports just because you're employed? You're
Absolutely. I'm
creating
just
a
gonna,
reliance. Sorry.
yeah, I'm sorry. I wish we had so much time to do this. I have to say, Ty, Emilio, Nicole, I don't know any of you before this, and I watched your videos, and I feel I knew you so well, and I am so grateful to you for all of the work that you put in to make the videos themselves, because they are going to live in perpetuity in our Clearly Research Collective on our website. And I know I will be reaching out to every, disability studies academic I know come January to say, you want material, here it is. I've hit this hard barrier of 1220. I know people have been asking for more of this. We want to do more as well. Hopefully in 2026 I will see you all again, and I've got so many notes in front of me, and if I need you on something, I know where to find you. Thank you all so much. And Amanda, I'm going over my time, and I'm going to have my wrist slapped by you. But Trevor gave a great phrase that bootstraps need boots, and that's absolutely correct. So thank you, Trevor, for that as well. Okay, Amanda, over to everybody.